보내게 하는
Okay, from now on, I'll start ECG conference. I'm presenter Dr. Cho. When I chose this case, in the morning, today morning, I understand. I realized I misunderstand about this ECG, but it was too late when I realized.
Okay.
You can designate the reader, ECG reader, in this room. Anybody.
How about Georgia?
Georgia, you are the first reader.
Can go to the screen, take a look closer. Don't look at the side ECG. You will miss it. Okay, I'll come this way, far away. You can see all that, be great.
regular, regular, and happy with your underwear 60. Oh, please.
We have a traditional rule. If the speaker is silent more longer than 5 seconds, the moderator should move to another one. Okay?
You leave EKG there. Let us no, go back. Leave EKG up there. Yes, go back. Yeah, we need to interpret the ECG first. Okay. So then, let's ask people what do you guys think? EKG.
First of all, too slow, 40 beats per minute.
So EKG reading always has to have a certain sort of a sequence for you to not miss it. Everybody has their own rule, so it doesn't matter. First of all, Dr. Bach says the rate is slow. That's the number one. Number two, do you see P wave anywhere? No? You sure? Any kind of P wave? P wave could be retrograde, could be upright, it could be all different. So baseline ECG is quality is okay or is bad? It's also because the baseline is a kind of little wavy, it contains some noises, you see? So when you read the ECG, you need to put that in consideration. So question I have for you, what is it after QRS complex, this small notch, is that a potentially P wave? Come and goes, right there, right there, right there. If that is a P wave, timing is a little bit different R to R, right? Might be cycling dependent variation. In other words, if you look at the first QRS complex, that notching to the second one is a longer interval, then shorter, that disappears. So you see this? So this cannot be, or possibly may not be part of a QRS complex. So what else could it be into the ventricle's absolute refractory period when you depolarize, give another notching like that? Could it be part of a QRS complex with a regional conduction delay? Or could it be P wave, some other chamber, right? So those are things you need to start describing. We are not telling you what is wrong or right, but we try to make observations or comment to us.
What about J wave?
There we go. That's a part of regional abnormality that we are talking. Okay. How about, what do you think about this patient QT? Is short or long? It's kind of a T. There's no S segment in this patient. T wave right after the QRS complex. You see? So you wonder if this is the QT interval is shorter than normal, then you would argue what the Dr. Park raising, J wave syndrome, short QT syndrome, so on. And I don't see, agree with you. I don't see very distinctive P wave. There's a maybe suggest hint of a P wave. Okay. Next, QRS complex, normal, abnormal. Not besides just a slowing. What else do you see? RR interval is not regular. Okay, you see? There's maybe rhythmic pattern variation. So you may argue, oh, this could be sinus arrhythmia from the breathing, for example. Or could be another mechanism. But you can raise that possibility. Or because arrhythmia itself is get short, get longer, then short, something like that. But there's no pattern I can see. And then other possibility is what? What a possibility of atrial fibrillation can do this?
Block.
So atrial fibrillation with a complete heart block can do this. Okay? That's why you don't see this clear P-wave kind of noisy pattern S segment, not a true noisy, but it could be fibrillation. Course very, very fine, course fibrillation ongoing, and then patient in complete heart block.
And QRS morphology is
Is
also
consistent with
very
another,
bizarre.
right? If
even
you
though
look
it
at,
is
yeah,
natural.
if you look at the QRS complex, where is QRS complex coming from? Is junction rhythm, you think?
Could be,
Oh,
that's true.
could be a proximal conduction system. I don't think we can see that precise, but you could argue this may not be true nodal conduction complex. Could it be escape rhythm due to the heart block coming from proximal conduction system? Okay, those are differential diagnoses. Now, what is the meaning of a short QT with a U wave? This is a T wave. This is the U wave, I think. You see it. Prominent U wave mean anything to you? In EKG writing, probably. Where did the U wave come from?
Physiologically, U wave stands for the papillary muscle repolarization. because
Oh, yes.
it is
Oh,
latest repolation
Right.
point, but this patient could be have apparent structural heart disease, so other repolation abnormality
mhm.
generates
Right.
this.
So then I think
Yeah.
you could argue that this patient U wave is discordant to the QRS complex. This is important. QS, U wave positive. You see? U wave always goes along with the QRS complex normal individual. This is a discordant. Okay? So those things are important reading that you have to make. Anything other comment beside that? QRS duration is slightly wider if you consider that secondary notching here in the lead 3 is slightly wider than normal, therefore maybe favorable not the junction rhythm, but maybe proximal conduction system rhythm. But then again, this is all differential diagnosis we can put it on the CCG. Okay, and patient has incomplete right bundle pattern. Okay.
So I would like to listen to Dr. Joe's first impression.
For the-
Or you misunderstood it at first.
Uh, it was right diagnosis. It was
No diagnosis.
Okay,
Your impression.
it was same actually, but
Okay.
I say later.
Okay, good. The next, that's okay.
This is a local group.
Okay. Yeah. Now you can see better fibrillation wave in the V1. Go back there, V1. You see that V1, you can see it. Perhaps the atrial fibrillation a little bit better, maybe. Yeah. Okay.
And it was female 88 years old. Her chief complaint was general weakness. And after influenza A diagnosed, April 21, she had a poor water intake with severe general weakness. At the local clinic, ECG showed bradycardia, so she referred to Severance Hospital. Vital sign was like that. Artery was 44. And the review of system, she had bradycardia, numerical history, hypertension, CKD, heart failure with preserved ejection fraction, atrial fibrillation, mitral regurgitation, and she had decoction
So why the digoxin important here?
because she had bradycardia.
What was the disease level?
Serum deduction level.
Yeah, it was.
Okay, so digoxin inhibition important because of short QT. Digoxin is only few drugs that make a QT interval shorter. Another drug can do that would be a sodium channel blocker, mexilatin. That's why you treat the long QT, like that with the mexilatin. Okay, yeah, it is pharmacological drug therapy. We use in electrophysiology. So digitalis.
And chest X-ray was normal heart size, and she has a prolonged COPD. And it was transcardiography.
Okay,
Yeah, it was enlarged array.
here's about
This
this.
is what results. Large array and it's valvular disease, maybe due to atrial fibrillation. And this is the lab findings. With electrolytes sodium 128, potassium 3.8, fluoride 85. And the decoction level was 4.8, was elevated. So
So this is a basically digitoxic patient, and that's why your QT is shorter, and then have this typical U wave abnormality with this going on. Yeah, that's a classical digitoxic ECG. Now, this patient has a creatinine at 1.9, 1.8, so she's a prime candidate. Small lady, old age with a renal failure. So her body size is small, and your creatinine is at 1.8. That means you got severe renal failure. This creatinine disproportionately.
What dosage of the deduction?
sorry.
What dosage?
Was 25.
0.25. Yeah.
Yeah, yeah. Oh,
Zero
QD
point five, very high dose.
0,
1 to 5.
0.25 QD I remember.
Oh, 1 T.
Yeah.
Many people,
High.
many people use in the United States 0.25. The body mass is great as long as the renal condition is normal. Asian might be smaller body mass. It doesn't maybe use a half a dosage of it. But even in renal failure, probably not advisable to use it in conjunction with the beta blocker because your cytochrome P metabolism in the liver, beta blockade, digitalis probably will compete. And then I think in this patient, I'm surprised did not have a bidirectional VT. That would be the disaster here. Digitalis can give you a bidirectional VT from Purkinje, so maybe be really careful.
Generally, we use the half dose
Right.
injection
Korean is a
for
trend, yes.
Korean people,
Yeah.
but especially in the older patient, if they cannot eat because of general weakness,
Mhm.
renal failure aggravated, and all of a sudden,
Yeah,
this
pretty
patient-
nice. And I think because of history of atrial fibrillation with the RVR, they probably try to increase the dosage. So this patient would be potentially, alternative option to treatment. You need to think about it. So what you're going to do with this patient? That would be the next question. Since we are doctors, got to treat this patient. If you consult this patient, what would you do? Options. So this patient could be candidate for the AV junction ablation with the subtle pacing, for example. That would alleviate the need for beta blockade, digitalis. Okay. And what other options do we have? AFib ablation. I don't think nobody wants to AFib ablation this patient. Okay. And
just
then
stop the junction.
we can stop the digoxin, and then hopefully bisoprolol control her rate. Yeah. But if it doesn't, then you end up coming
It's 88 years
88 years. Conservative approach, yes, because of COPD, many other things. But then always the options you need to take are plan A, B, C, always. Don't plan only one. So you make a chart that clear. These to show that you thought about this process. Okay. So treatment plans of stop the digoxin immediately, whether she need the digibinder treatment right now. Indication, yes, she does. Okay, you need to inject the digibinder right away and then recover, see what it does. What's the best way to assess the after digitalis off that the RVR response? how you can assess that. Front telemetry, let it walk around a little bit, inpatient setting, how fast respond to the exercise and so forth. That'll give you some idea. But she may not be tolerated too much beta blocker because of COPD long.
Last 5 or 10 years, the digoxin, there's a many report that digoxin increased the mortality
Right.
and exacerbate the cell death. So I didn't use digoxin, but the last 4 or 5 years ago, digoxin became the class 1 indication for AF rate control in guideline. All of a sudden,
That is
do you
because
know the background?
because of guidelines, accumulative of many smart people put it in together and ideas. But digitalis because still the most popular drug in third world country. The United States, Europe is only 20% power global population. Rest still dependent on drugs. Okay, so I think that's probably more socioeconomic and also cheapest drug do you have. This patient may be a good candidate for the verapamil, calcium channel blocker, for the AV node blockade rather than bisoprolol or anything like that. So you need to make this plan right in the chart. That's your consultation number. Okay.
So this-
Okay, very good.
Yeah.
That's the after digoxin removal.
Yeah, right.
KBD binder? No, just self-improvement.
Yes, stop and self-improve.
Okay.
Actually, when I chose this case, I saw I see depression with scope.
Yeah.
And, short QT interval.
Yeah.
And, with biphasic or a T inversion.
Mhm.
And in the morning, I find it that digoxin therapeutic effect and digoxin toxicity effect is different. Yeah. Downsloping and T wave inversion and short QT interval is just digoxin therapeutic effect and slow SVR conduction, AV conduction, and something like that was digoxin toxicity effect.
So, obviously, a lot of people, tended to use a lot of amiodarone. And when you use amiodarone in Korean population, try not to give it results. They potentially one another and then end up having trouble. So, digitalis went out of common use in the United States because if you do nocturnal six-sinus syndrome, digoxin is markedly bad. They prolong sinus arrest during the sleep much longer than usual, so on. That is one of the evidence that they increase the mortality. They tended to have escaped VF arrest. So that well documented.
Affects the sinus.
Yes,
function also.
as well, absolutely, because the perinodal exit block. So that's why, Professor Suju Kim, Monfort, that's his program. That he did the early trial. And when he gave a lecture in KHS many, many years ago, he presented his data. So that's the last time I think he came to Korea. So that he wrote a paper in New England Journal of Medicine, actually. That's his, yeah. So that's why digoxin went out of fashion.
I thought that digoxin affects only AV node.
No. Because the digoxin affect also Purkinje. That's why they got bidirectional BT when the GG toxic.
It is in the toxic dose.
Right.
Right.
Same way. The toxic dose is depending on the patient renal function, many other things that you said. So these fluctuate quite widely. They are not really stable. And the drug that not steady level is very hard to reach. Digoxin. That's the problem, I think, in these studies.
Generally speaking, the mechanism of digoxin is parasympathetic mimetic effect.
Take a little bit of, but then,
Okay, it's different to the beta blocker.
all right.
So during it cannot control the AF rate control during exercise or emergency room. Did you experience any experience in the emergency room for the patient with AP rapid medical response after injected with digoxin? It controlled acutely
Yeah.
No, never.
Yeah.
because in those patients is a hyperallergic condition, the digoxin doesn't work. But in all those patients, they do not move a lot. Not the so those patients, the digoxin works well, but this kind of complication and the adverse effect can occur.
You know,
Question.
Go ahead.
Sometimes I experienced small patient with female or Caucasian patients with AFib RVR when I when infused decoction about 2 ampoules, then sometimes severe hypertension or cardiac arrest.
That is not has to do with the mechanism of AV node block. That has to do with probably Purkinje network and the effect of bidirectional VT. So look at how the onset of the tachycardia. They typically have a polymorphic appearing VT. That is a bidirectional VT actually, first few beats. Yeah, it is well known, yes. So digoxin loading IV is that in the United States recommended 0.25 milligram every 8 hours, not acute loading. We don't do that. So if you give a 2 ampoule, it will be 0.5 milligram. I don't know how much IV digoxin dosing of Korea is.
Well,
United,
just 1 gram.
yeah, but United is a 0.25 milligram ampoule. So we don't give all together every 8 hours apart. Total dosing would be 0.75 milligram, and then watch to see how it does. But instead of taking such a risk, okay, best thing that if a patient is anticoagulate, just cardivert. That would be much easier thing to do. Okay, atrial fibrillation also need to be time-to-time cardivert. So you need to weigh the options of a cardioversion versus no cardioversion, drug therapy, so forth. So always keep that in your mind. In atrial fibrillation, sometimes not that benign rhythm. Okay, especially when it come along with the ischemia. It's bad news.
Okay, in which patient do you give a digoxin? In outpatient?
Difficult question.
No.
Usually I use heart failure with reduced ejection fraction or mildly reduced ejection fraction.
I think you recommend the atrial fibrillation ablation in those patients.
Of course.
But,
I prefer.
well, I mean, digoxin is a drug that we have a lot of. If you use a proper thinking, you can get away a lot of things. In a third world country, if you look at the atrial fibrillation patient population, more than half of them on digoxin. The reality, that's a reality. Okay, so knowing what is the digoxin can do as a doctor was important, especially if you're going to serve in the third world country, because that's the only medication they got sometimes. No other drugs available in that country. So you got to work with what you got. That's the bottom line. We just got to know it. That's all. Okay, thank you.
Thank you.
Thanks for everybody.
you.
Our early morning conference, great. Learned a lot today again, so see you